My name is Jill Feldman, and I'm a lung cancer patient and advocate. It's not easy, and I just want to add one thing. It's okay to not be okay. There are days I don't want to get out of bed, and there are days I feel like I can conquer the world. But thanks to research, I'm sitting here today.
This is a very, very, very rapidly emerging field and evolving. The technology is changing monthly.
I am alive. I've lived with lung cancer for 15 years because of these advancements.
I do think that there is a world in our lifetimes, Jill, where cancer will be a chronic treatable condition, similar to other things like diabetes and hypertension and HIV.
One of the most important aspects of treating lung cancer is understanding whether a person has biomarkers or not. And biomarkers can mean a bunch of different things. We are joined here today by Dr. Christine Lovely, who is our wonderful guest. She is a physician scientist at Vanderbilt Ingram Cancer Center. Her clinical practice and her research focuses primarily on the care of patients with lung cancer.
So I'm so grateful for the opportunity to connect with you all today and to be able to have this conversation with Jill.
Really, at the time that you started, lung cancer wasn't where it is now. So that is, hope wasn't associated. I wouldn't have used the word hope in the same sentence. So that's what makes it even more remarkable. But as we know, it has changed.
All the unbelievable advancements in lung cancer. It's incredible how fast the field is moving right now. And that's good because the need is high. This is the #1 cause of cancer-related deaths in the US. So, and anyone is at risk for lung cancer.
You and I both have had a front row seat to the evolution of biomarkers, which has led to this revolution of advancements in research and treatment, allowing patients to live longer and better. And so just in general, for the audience, biomarkers can be found in tissue, in blood, in other bodily fluids, and they're actually used to diagnose a disease, to determine how aggressive a disease is, and or sometimes they can predict how somebody will respond or how the cancer will respond to treatment. But when we talk about lung cancer, Dr. Lovely, what is biomarker testing? What are biomarkers and why is it important?
So what are biomarkers? So I will also say that when you patients and providers, family members, caregivers, when you enter into a cancer clinic, first of all, nobody wants to be in a cancer clinic, no matter how lovely your doctors are, the nurses, the people that you meet there. Nobody wants to be there, and we all recognize that and have huge sympathy and empathy for that, because even though cancer is an incredibly common problem, nobody wants to find themselves in a cancer clinic. When you are there, you start to immediately learn there's a whole new vocabulary associated with the world of cancer. And we're going to think about some of that vocabulary today. And one of those words is biomarker. And even within the word biomarker, there's many, many, kind of uh, vocabulary words even within the biomarker terminology as well. So let's relate it to something that makes sense in common everyday life before we get into the science. When you build a house, you need a blueprint. Architects have blueprints for building houses. They have a map for how we're going to build this house. It's a blueprint. That's how they design the house. That's how they figure out all the different components, the roof, the walls, the bathrooms, the plumbing. Cells in your body, including the tumor cells, are very similar to that. There is a map of how those cells are made, how they behave, how they act in your body. That map are things that we call DNA, RNA, and protein. So that's how I kind of explain it to my patients. You need to have a blueprints to build a house. You need to have DNA, RNA, and protein to build a tumor cell. The biomarkers that we are looking at are those elements, the DNA, the RNA, and the protein. They are the parts, they are the architecture of the tumor cell. And what we are trying to do as doctors is figure out, why did this blueprints, what happened to make this go wrong, to make a normal cell in your body become a tumor cell? Because cancer is just our own bodies gone wrong. It's not something foreign. It's our own bodies where the blueprints have changed. Those blueprints are the DNA, the RNA, and the protein. When we say the word biomarker, we're saying, how did the blueprints, the DNA, the RNA, and the proteins change? And can we detect those changes to help us pick a better therapy for our patients?
I think it's really hard for people to kind of grasp that, and I like that you use the analogy that it's something everybody can relate to. And, kind of to emphasize, there is a difference though between inherited, they call them germline
Yeah.
biomarkers. That's, present in our DNA and all of the cells in our bodies. And then there's what's called acquired or somatic. And
Yeah.
those are the biomarkers found only in the cancer. They cannot be passed down, to your children that we know of. Now, we are looking at some inherited biomarkers. We're doing research in that area for lung cancer. We are not there yet. So the biomarkers we are talking about are the DNA, the RNA, and the protein of the cancer.
You're exactly right, Jill, that this, in the majority of cases, not 100% of the time, but in the overwhelming majority, the biomarkers, the blueprints, the DNA, the RNA, the protein that we're looking at, the building blocks of the cells, it's something that's changed during your lifetime, not something you're born with, something that's changed to make a normal cell become a tumor cell. And so, not 100% of the time, but the majority of the time, these are things, the biomarkers we measure are not something that you're born with, not something that you pass on to your children and grandchildren, but something that's changed over the course of time in your life for a variety of reasons, some of which we don't understand honestly, that's caused a normal body cell to become a tumor cell.
So now that we've established biomarkers in the cancer, how do you measure them? How do you test them? Why
Yeah.
is it important in lung cancer specifically?
This is the most important thing. Like, who cares about biomarkers? We're not just measuring or doing all these tests just because it's some, you know, area of academic interest. Like, hey, we're not asking patients to undergo testing just because. We test for biomarkers in tumors because it helps us pick the right therapies. And sometimes a biomarker will select for a therapy. Like, if you have biomarker A, then you get drug A, but you don't, if you have biomarker A, you don't get drug B. It's really important. So when we talk about precision medicine or personalized medicine, biomarkers are at the heart of that. And maybe if you're listening, you've seen advertisements for personalized medicine or precision medicine. Biomarkers are at the heart of driving personalization of care. And biomarkers, we're talking about cancer and specifically lung cancer right now, but other areas of medicine have biomarkers to help select therapy as well. So this is not something exclusive to cancer, but really in the context of cancer and lung cancer specifically, we're saying we're looking for biomarkers the majority of times because it helps us to pick the right therapy for our patients, to deliver personalization of care. And that's really, really important. And there's been decades worth of experience now in teaching us that we can become more refined in how we treat lung cancer, more nuanced in how we treat lung cancer when we look for these biomarkers. The goal is to put more treatment options available on the table for our patients, because what we none of us want is to say there are no options for your treatment.
Definitely.
And we want to be able to deliver treatments in the most refined way, the most precise way based on the characteristics of the tumor. So that's the goal. Overwhelmingly, there are other circumstances. Sometimes we use biomarkers to help with prognosis, which is not the same thing as picking a therapy. But for the context of this discussion, we're going to say we're looking at biomarkers because we're trying to pick a therapy for our lung cancer um, treatment algorithms.
Mm-hmm.
So how do we do that?
How do you do it? Yep.
Yes. Okay. There's a couple different ways we can do it, and I'd say this is an um, evolving area as well. So two ways, and we'll talk about both of them. The first way is to test biomarkers in the tumor biopsy, and the second way is to test for them in the blood. That's the newer way. And I will start by saying they are not exactly the same, and it's important that we talk about them both. Let's start with talking about the tumor biopsy. So when patients get a diagnosis of cancer, and we'll focus on lung cancer here, we have to make that biopsy by looking at whatever the abnormality is, like a mass in the lung. They take a piece of it and they look at it under the microscope. The traditional way is to look for the biomarkers in the tumor specimen, the biopsy or the surgical sample. And within that, you basically literally grind up the tumor and you extract the building blocks, the DNA, RNA, and protein, and there's ways to measure each one of those building blocks, DNA, RNA, and protein. That's a traditional way to do it. That's still the foundational way to do it. More recently, there's been an explosion, literally, of technology where we can actually sometimes find circulating pieces of tumor in the blood. And for the majority of time, we're talking about pieces of circulating tumor DNA in the blood. Now, this is a very, very, very rapidly emerging field and evolving. The technology is changing monthly, literally, to refine technologies for what we call circulating tumor DNA or ctDNA. Big take home messages. It does not replace having a tumor biopsy. A tumor biopsy is still absolutely necessary. It can help us to find the biomarkers, but not every patient has circulating tumor DNA. If we find it, it can help us to make the treatment decisions if we find a marker, but it is not exclusive. Tumor testing and blood testing to find ctDNA in the blood are complementary, not exclusionary of each other.
I want to touch on, on something that's very sensitive in the community, the science behind these biomarkers and targeted therapies, matching the right treatment with the right person. It is exciting, and I understand why it's exciting, but a large amount of people don't have biomarkers, or there isn't information found. And a lot of, so, but that doesn't mean that there necessarily isn't a biomarker that they haven't discovered yet, or that doesn't mean there isn't a great treatment option. So can you just expand on that a little bit?
Yeah. Yeah, thank you, Jill. This is an important point. We don't want to set the expectation that every single patient with lung cancer will have a biomarker, and in the sort of bounds of this short conversation, it's hard to even get into all the details needed to understand these biomarkers. Like, there are literally conferences in our area, as you know, where people spend days talking about all the different biomarkers and the DNA biomarkers and the RNA biomarkers and the protein biomarkers, and they're different. And we would actually need to talk about each one of those separately. And so, if we just say for a minute, let's take the scenario of the DNA biomarkers. And right now, there are about 10 DNA biomarkers in lung cancer that have matched therapies that are FDA approved. 10's a lot for cancer, but not every lung cancer patient is going to have one of those. That doesn't mean anything good or bad. It just means that maybe there's not a DNA matched therapy for that lung cancer patient. It means there are other tools we can use: chemotherapy, immunotherapy. Everyone with lung cancer, should have tissue to do staining for something we call PD-L1, which is a marker we use for immunotherapy. So there's different levels of biomarker testing.
And I think that is really important. When I was first diagnosed back in 2009, they had just started testing for two mutations. And what was interesting about that was I was originally stage 1, and I was going to have chemotherapy after surgery as adjuvant therapy because I was young and I had that family history and my kids were little. And even though it was minimal benefit, I needed to do everything in my power. But everyone recommended I have this biomarker testing that, all of a sudden it was, wait, chemotherapy might not be the right option. It might be this targeted therapy. And so it was one of the best decisions, uh, taking the targeted therapy as adjuvant therapy because the cancer did keep coming back. And I think, maybe it slowed down, though, the growth of the cancer. Maybe it prevented it from metastasizing. I don't know, but it really, really makes sense that the information or the lack of information, both is the information needed to guide it. So it's really incredible.
2 points there. One is just really to emphasize, you mentioned no information. And let me just clarify for everyone listening: no information in the context that Jill is using it means you had biomarker testing, but the result of the biomarker test was that none of the biomarkers were detected. So no information means you had the test, but none of the biomarkers was found. That is very, very, very different than not having the test at all. It is
Thank you.
incredibly, incredibly important to have the testing done.
I think that's a great segue into, is everybody testing, and how does the conversation even get started?
Yeah, and I will say, there's many, many different ways that, just like there's multiple different ways to do the testing, multiple different companies that can do the testing, there's different ways that different health systems do the testing. So at the end point for every patient should be the same, in that you get the testing. How do you get to that end point is going to vary based on where you're getting your care. It is very common for patients with lung cancer to have you have a team of doctors. I am a medical oncologist, so I am like the doctor who gives chemotherapy, immunotherapy, targeted therapies. You may also be seeing a thoracic surgeon, the doctor who cuts out a lung cancer. You may be seeing a radiation oncologist, a doctor who gives radiation to help treat lung cancer. You may be seeing a pulmonologist, a doctor who is specialized in doing procedures like bronchoscopies, where they go and put a tube down your throat to help get a biopsy of the tumor. There's doctors who you don't even meet, like pathologists, who look at the cancer under the microscope, radiologists who read your CT scans and your MRIs. There's a huge team of people who are really thinking about every single patient's case and bringing it together to come up with the best plan for every individual. Who actually orders the actual biomarker testing is different from place to place. And so I can't say, here's how everyone does it. I can say, here's how we do it at my center. And sometimes I'm the one ordering it. Sometimes it gets what we call reflexed, where the biopsy will be done and the pathologist will reflex the order. They'll put the order in before I even see the patient. I think that the most important take home message is the end point should be the same. The patients should get biomarker testing. If and this is a discussion that ultimately is going to be one that your oncologist has with you. And it's usually the medical oncologist, like somebody like me, because we're the ones prescribing the biomarker directed therapies like the chemotherapy, immunotherapy, targeted therapies.
And you're right. You hear surgeons, pulmonologists, oncologists, primary care doctors if they're the quarterback.
Yeah.
Um, and I think people always ask me though, when should I like start talking about it? How do I start talking about it? So, and because that's the first thing that, the most important question to ask, I always say is, was biomarker testing done? And if it's before taking a biopsy, if it's before surgery, make sure biomarker testing will be done. If people are hesitant or don't even know where to begin, like what would be your advice on how and when to bring it up with their doctor?
I think it's fair to just ask, is my tumor going to get tested for biomarkers? And whether that's the medical oncologist or the surgeon or whoever you're meeting with, because chances are that doctor is talking to the other doctors on the team as well. And so, and if they can't answer it, then they will refer you to another doctor on the team. But I would say it's fair to ask whomever. My bigger advice would be write down your questions, because what happens so commonly is and this happens to all of us, you go to a doctor's visit, the time feels very, very short. It can feel very overwhelming. And I think I often see if you have your list of questions in advance, I think people leave feeling more empowered afterwards. Like, okay, we've checked all the boxes. I feel like I can exhale now. We've addressed all the questions that I wanted to address. And there's a huge comfort in that, huge, huge, huge comfort in that, saying, okay, I entered with my questions and I left with my questions being answered, and to the best of the ability that the doctor could answer them or the care team could answer them. And so my biggest advice would be write your questions down and bring them with you.
I think communication is key, and we could have a whole talk about that. Here's another one that's like, happens because of the rapid advancements, and that is you have biomarker testing. And if you have a biomarker where there is an approved therapy, then there are steps that are, kind of a protocol, what doctors are supposed to follow. And you're put on that therapy. But what if there are biomarkers found, but there isn't an approved targeted therapy? And those can be called different things on the reports, but it's always a source of anxiety. What does that mean? And if you could talk a little bit also about clinical trials in this context, that would be great.
So the first is, the tests, and there's actually a third topic that I'm going to throw in there. So one, we're going to talk about two kind of big picture topics. One is, what if there's something detected on your biomarker testing, but it doesn't match to a therapy? That's a big topic. The second is clinical trials. Before I get to either one of those, earlier Jill mentioned a word that's a really important word that we haven't gotten into, but it's kind of a cousin of the word biomarkers, and that word is mutation. Let's discuss dig into that word for a minute because that's an important word that you'll hear a lot. It's another one of the vocabulary terms that you'll hear a lot. Biomarker testing is looking for mutations. What is a mutation? A mutation is simply the word that we use for the change that happens in the DNA. And let me give you an example. I'm big on like make it something I can relate to. So if I say DNA, which is the blueprints of our cells, right? The DNA reads like a sentence. So if I tell you a sentence, the big dog ran, you would understand that sentence. It makes sense to us all. If I change one letter in one word, if I change DOG to DIG, it becomes the big dig ran. The sentence doesn't make sense anymore. Changing DOG to DIG, just that little change, an O in dog to an I, changes the word dog to dig and changes the sentence. Mutations in DNA act the same way. One little change in one little letter of the DNA changes the way the DNA reads. That is what we're looking for when we look for mutations in DNA. It's as simple as that. Think of that example. It's just changing the way the DNA reads, and the sentence doesn't make sense anymore. It's not what it was intended to be. That's what a mutation is.
I'd like to just say, and point out again that my family history illustrates hope and progress and everything that we've talked about with lung cancer. When my parents were diagnosed, they had three treatments options: chemotherapy, radiation, and surgery. And often the benefits were minimal and the treatments were worse than the cancer itself. And I am alive. I've lived with lung cancer for 15 years because of these advancements. I have benefited from them. I have benefited from targeted therapies, and I am grateful for that. But we still have a long way to go. And so, what is your take on the future? What do you see as being most promising and hopeful for people?
I think this is a really good question and a really important one because, I mean, if you think about any aspect of our lives, right? Like how things were now versus 5 years ago versus 10 years ago versus 20 years ago is vastly different, right? Like when I was a kid, there was no internet, and now we're completely dependent on it. And so, just to think about the possibilities are amazing. And I do think that there is a, a world in our lifetimes, Jill, where cancer will be a chronic treatable condition, similar to other things like diabetes and hypertension and HIV. And I don't think that's out of the realm of possibility. And I think, how do we get there? I think, I'm going to say there won't be one solution, it'll be many. And it won't be just medicines. It's going to be a big, thinking about lifestyle factors. Hugely important. We don't talk about it enough. I think hugely important. I am certainly not an expert in diet or exercise, but I think this is incredibly important. I think primary prevention and screening incredibly important. How do we screen for lung cancer and any cancers? And then, are we going to be able to prevent every single cancer? I no, but having treatments, novel treatments, especially treatments that can activate your body's own immune system to keep the cancer at bay, will be incredibly important. We already see this. I see this in my clinic every day. Patients who have dramatic responses to therapies that activate their immune system to fight the cancer, and it's remarkable. So I think that there is unbelievable hope in the future for this dreadly word we call cancer, lung cancer, and other cancers. There is still a long way to go and a lot of work, and it won't just be one solution, but multiple. But I have so much optimism that we will get there.
Yeah, I do too. And I am grateful for the hope you provide. So thank you for joining us, Dr. Lovely. It was so wonderful to have this conversation. And thank you for the hope that you provide to patients and families.
Jill, thank you so much. There is nobody better to be hosting this than you. You inspire people around the world and are so beloved by the lung cancer community and the cancer community in general. So thank you so much for all of the inspiration you give us all.
Thank you. My mom used to say it takes one candle to light a dark room. You know, light one candle and then how many are lit from that candle. And so, if it makes a difference in one person, it's like the butterfly effect, it travels. So I guess that's why I keep going. It's not easy. And I just want to add one thing. It's okay to not be okay. There are days I don't want to get out of bed, and there are days I feel like I can conquer the world. And so, where I am now in my advocacy, I didn't get here overnight. It's been years, and it is, and I'm not always okay. And that is okay, as long as we keep moving forward. That's my why. But really, at the end of the day, my real why, of course, is my family and my children.